Let me, first of all, welcome you to Sinai Auditorium. Rebecca Hart, who is the organizer for this on behalf of Longwoods, calls this the official home for Breakfast with the Chiefs. And therefore, I'm the official sort of host. It's like Alex Trebek and Jeopardy goes hand in hand. The chief that we're focused on today is Dr. Bob Bell, Deputy Minister of Health, and a lot of us know who Bob is, and his track record certainly speaks for his reputation and his accomplishments. And it's my pleasure to welcome both Bob and his interviewer, Dr. Michael Guerriere, who is the Chief Medical Officer for TELUS Health. It's great to see you, Mike. I haven't seen you for a while, being here. I also want to take a second to thank today's sponsors, all of whom are represented here this morning. We appreciate your support, and we want to acknowledge you at LARC, FHI, IBM, Roche, National Research Corporation, and PwC. Just before I turn the mic over to Michael to get us going, I want to share with you an exchange of emails that took place last week when Rebecca was preparing for this session. And she wrote Mike and Bob and myself, and she just, basically it was a bunch of stuff and about this morning, and she described it as just a few housekeeping items for next week's Breakfast with the Chiefs. So Bob responded to Rebecca, let's get this here, and he said, "Sounds good. Look forward to interaction with good friends Joseph and Michael. I remind Dr. Guerriere of my history and experience in martial arts and assure him that if he asks a difficult question, I will simply dislocate his right elbow." This is from our humanist Deputy Minister of Health. So I thought that was pretty neat. So I emailed Bob and I said, can I use in my intro? I exploit these opportunities, right? So Bob wrote me back and he said, of course, but remind the audience that I would likely be the only person in the room who will know how to fix it. For those two people who don't know what I'm talking about, Bob is one of the most renowned orthopedic surgeons, probably not only in Canada, but certainly in the world. So Michael weighs in and he says, I'll be sure to bring a sling. Looking forward to it. Now, Mike, I don't think you brought a sling, but I want to make an impression as a Deputy Minister that the Sinai Health System, and Marion will vouch for this, is a caring organization. And I have bought a sling just in case things break down. Mike.
So just in beginning, Bob, I have to say that it's a rare treat to have an hour. I think we're all in for a rare treat to have an hour talking with someone who's had such a interesting and varied career. Somebody who starts clinically, does, real landmark research and really has an impact from a research perspective. And that in itself is pretty incredible because very busy clinicians often do research, but they don't necessarily have a real impact. Then to move on to a very successful administrative career, and now to move into the area of public policy and public administration. It's not many people that are able to navigate through those kinds of transitions.
And Michael, if I can say, of those three careers, the only ones that I had any training or knowledge of was the first one. The other two were just making it up as we go along, as you well know.
Well, unfortunately, Bob, you're in good company on that front, I think. But before we talk about anything specific, you've been about 9 months in the job. How's it going? What kind of surprises have you experienced? Like, just what's the transition been like?
Yeah, thanks, Michael. Thanks for those kind words. And before starting, Joseph, thanks for your comments. And one of the things that doesn't surprise me, but it's useful to get a little bit of distance on, is the innovation and creativity in our system, right? And I think you run the risk breathing the rare air of Hepburn Block and Queen's Park of thinking that you actually have a degree of control. And thank God you don't, because you can't control the creativity and the innovation that occurs in our system. In various places it occurs in home care, where a visiting nurse figures out a way to keep a patient vital, enjoying life at home, who's getting dialysis at home, who's getting managed for complex conditions that really would suggest you should be in complex care, but that provider is providing innovation at the bedside. And Joseph and Marion, what you two have accomplished with your teams in putting together a new model for home and hospital, community, and long-term care and rehab care, and putting together new models for how they get supported across the continuum. I think that's what we're all thinking of. So congratulations to what you two have done, and thank goodness for that innovation. It means that we're not controlling, nor should we control. So the other thing I've learned, apart from that reflection on the creativity and innovation in the system, is the wonderful resource that Ontario Healthcare has in the Ontario Public Service. You know, we've got a bunch of really smart people who, there are a bunch of them in the audience, and I apologize for this, to my surprise, you know, what I've learned is they really understand our system pretty well, and they know that. They know they can't control the system. They also understand the levers that we do have, the statements that we make about where we want the system to go on behalf of Ontario patients, the understanding that we have about what Ontarians want, the fact they want better access to primary care within 24 hours when they're sick, the fact that they want to get more care in the community, they want to stay in their homes. The OPS understands this. So we've got a pretty good sampling of what Ontarians want, and we've got a pretty good idea of what the levers are that we have opportunity to pull. And you know, the other thing is the really unbelievable opportunity we've got with a a 3-year runway of a majority government, a Minister of Health who understands the health system, who's worked in the health system, who says, you know, patients first as the title of the strategy that we're pursuing. This is a huge opportunity, and it's like the sense that I've got in the back of my mind in those usual 2:30 a.m. conversations that we have with ourselves is better not screw this up, because this is an opportunity to really create something special. And I think that's what we're all trying to accomplish, is something really special for Ontarians in a system that we're all rightfully proud of.
So Bob, what are you working on that you're most excited about, that you really feel has the potential to make a real impact into the future?
So there are a bunch of things, and you know, I think the Patients First strategy characterizes it pretty well. But you know, for me as kind of a hospital guy, right, a guy who spent his career, I'm like a hospital rink rat, that kid that plays in the ice after the Zamboni's gone away. I like hospitals, I like ORs, I like hospitals, I like clinics, I just like hospitals. So I really tried to learn about what happens in the community in the 9 months that I've been in this role. And the opportunity we have in the home and community, I think, is the number one thing that we're really focused on. You know, Susan Fitzpatrick's team, Nancy Naylor's team, is looking at the opportunity we've got in home and community care. And the opportunity is born of the fact that, number one, Ontarians want to spend more time in home and community getting care. That's where they want to be. And secondly, the system has remained sort of under the radar screen. And great people working in the system, but you know, multiple hundreds, if not thousands of contracts defining home and community care in the province, Michael, and an opportunity to actually standardize what Ontarians can expect. What can you expect for your mom? As your mom ages, and as your mom becomes somewhat infirm, living now by herself, your dad's passed away, and your mom's getting a little more frail, she's getting a little more forgetful, and you're recognizing, gosh, my mom's changed. I need to think about what my mom needs. And the question that Ontarians ask at a certain age, you know, the age that Michael and I are approaching or have approached already, is, you know, what can we expect the system will provide for our mom? And the answer is, we don't get a very clear response to that. And probably the answer is different if you live in the Erie St. Clair Limb compared to if you live in the Northwest Limb. And the service delivery model definitely should be different if you live in Erie St. Clair versus Northwest, no question. But the expectation of service and quality of service should probably be the same. So trying to bring some sort of clarity as to what the expectation of service is, expectation as to what folks who provide service get paid, huge heterogeneity in what they get paid, huge heterogeneity in how we contract for those services, and finally, and I know this will be music to Michael's ear, the opportunity afforded by the technology. It's not new technology. I mean, we know physiologic monitoring can happen with an iPhone in the home. We know that Kevin Smith has demonstrated that Skype can be an enormous advantage to providing home care in a cost-effective fashion. So the opportunity, we know Matt Anderson and Kathy Kimovich have shown in Central West, there's an enormous opportunity for implementation of telehome care that we haven't started to realize yet. So my number one focus, you asked me number one focus, it's figuring out how we provide more care, more cost-effectively, higher quality, more predictably, more standard. Matt and I were talking about standardization of care. We think hospital care is not standardized. Well, it's an even bigger challenge in home care, but hence a much bigger opportunity if we bring the power of standardization to work there.
So I'm glad you brought up my mother. She's never far from my mind. She lives about 5 minutes away. She's a retired college professor. She taught nursing for 30 years and knows her way in and around the system as well as you can imagine one might. She's in her mid-70s. She has some mild ailments, but she's well and living on her own. And if she were sitting here, she could probably rail on for half an hour about how hard it is to get access to her family physician, who happens to be at one of the institutions that we both had an association with in the past. Can't get anybody on the phone, fighting.
Fortunately, there are several of those. Mike and I have a checkered past. Don't assume anything from that comment.
And getting a referral, getting a prescription changed, finding out that she's been prescribed something that her benefits don't cover, so she's got to pay $200 a month for some medication. It just goes on and on. Like, it's an odyssey of frustration and bad customer service. And when I look at the time that I've spent in healthcare, the whole question of the patient experience is the one area I have real disappointment. That after kind of 20 years of, you name it, integrated care and quality agendas and patient-centered care and health links more recently, that when you look at it from the patient's experience, it really hasn't gotten much better. What can we do? Are there places we can look to that show an example of how you can break that down and get to a better sort of service level for customers? What do you look to as being things that might hold some promise to get a more responsive, more proactive system?
So yeah, that's a great question, because I think that actually after home care fits into the second priority that we've got. And actually the minister and I are just exchanging, we do a lot of communication, the minister and I, between 6 and 7 by email. We were exchanging information this morning about a couple of recent reports. You may have seen it referenced in the Star yesterday under a lovely picture of Dr. Tepper. It's a very nice picture, I thought. But it talked about the Commonwealth Fund's report of various jurisdictions' response to the needs of the elderly. And just an aside, we know from surveys that we've done in the Ministry of Health, if you asked Ontarians 6 years ago, what was their biggest concern about the healthcare system? They'd say, my biggest concern is if I need heart surgery, if I need cancer surgery, if I need my cataract fixed, I won't get access. They don't say that anymore. Now they say, My biggest concern is if I need access to my family doctor in a timely fashion, just like your mom, I don't know if I can get there. And the second issue is, and by the way, when I have that appointment with my family doctor, I may not get more than one question answered. I may not, have a satisfactory encounter. And just in the last few days, to go on the Commonwealth Fund, you've probably already been there since you're health wonks in this room, probably. But go on the Commonwealth Fund and look at the jurisdictional analysis of how well, 12 or 13 jurisdictions provide care for the elderly. And it's a Canadian experience. It's not an Ontario experience. And we know that Ontario is probably a little better than most provinces in providing customer service. But we are dead last. We are dead last as a nation in terms of that 24 to 36 hour access that the Commonwealth Fund always asks as a primary determinant of the quality of the healthcare system. And we remain dead last. And this is for seniors. Some of the integration issues there were good at medication reconciliation, I was pleased to see. But we're not great at having information from hospitals arrive in primary care offices when the patient returns from a hospitalization, as seniors may do. We're delighted that Connecting GTA and the CSWO project in southwestern Ontario and CNEO, I think are going to be an excellent solution to that issue. But the issue, doggone it, of seeing your doctor within 24 to 36 hours, we know that's possible. I mean, it happens 80% of the time. In Denmark, in England, it happens more frequently in the United States because now they're instituting new models like go see a primary care provider and nurse in Walmart, right? See them anytime. You see them within 15 minutes. And here we are in Canada. We've probably got one of the most expensive primary care systems in those jurisdictions analyzed, and we've got the worst performing. Not only that, I saw some data in the last 24 hours that looked at 6,000 Ontarians' experience with the healthcare system. One of the questions asked exactly the same question. The Commonwealth Fund, can you see your primary care provider, not your doctor, your primary care provider, within 24 to 36 hours if you're sick? And it showed that Ontario is no better than the rest of Canada, it's less than 50% of the time. What was stunning to us was that with the respondents' permission, we linked that data. They gave us their OHIP number in this telephone interview. So, we've got the rosters, right? So we looked at the rosters and we said, okay, if these people we're hearing from who can or cannot get access to their primary care doctor, how many of them are actually rostered into FOs, FIGs, PINs, CCMs, and how many are in fee-for-service care? And guess what? Access within 24 to 36 hours is substantially better if your primary care doctor is in the fee-for-service model than if they're in a roster model. So that's yeah, I can hear the buzz in the room. Huh? Yeah. So you draw your own conclusions from that, but I think we've got a need, and primary care providers want to provide great care. There's no question, but I think in the present time, it's our fault. It's the ministry's fault. We're actually providing funding for comprehensive care that includes advanced access. That we're saying that. And we're not measuring it, right? We're not measuring it in a way that allows us to manage the contracts that we got. So that's an issue for us, and blame on us. Blame on us.
So we've seen in other jurisdictions, more Europe and the US, this move toward accountable care structures that are measuring and providing incentive payments for achieving certain performance indicators. So it's not fee for service, it's not, it's not a capitated model, it's more of a, significant portion of the income coming from, achieving the performance levels that they're looking for. Can we expect something like that starting to come into Ontario? We're starting to see it, come into some of the other provinces. Certainly BC and Saskatchewan have been doing it. Right now, Alberta's required all their primary care networks to report on a whole series of quality indicators, so everybody's scrambling to be able to report out of their electronic medical record systems. Is that something that we can look forward to here?
Well, so, We had Dr. Ashish Jha, who's a professor at the Harvard School of Public Health, up last week. And we were talking through changes that are happening, the stage changes that are happening here. One of the things we really wanted to drill down on was what he saw as the potential success of accountable care. Not so much from an incentivized basis, but more from an organizational perspective. And he knows Ontario pretty well. He grew up in Canada. He grew up in Toronto, actually. His folks were at the university as grad students. So just imagine, we sort of talk through the structure currently. And just imagine if our LHINs were actually empowered as accountable health organizations, right? And if primary care quality, primary care planning was part of the approach that LHINs were expected to take. We have some LHINs, we look around the province, Hamilton's pretty well organized with respect to primary care. A couple of big family health teams and they actually have wonderful performance. They demonstrate their performance in terms of advanced access and other issues. So you can imagine that we can start a system where we put together large primary care groups that comprise FITs, FINs, a variety of different kinds of structures. Doctors would still get paid, and they still get paid the same way, and they still be responsible for distribution of their funding. That's not a question. But in terms of organization of those groups, and in terms of the quality that attends to that care provided, in terms of the planning, do we need a new family health something in Thorncliffe Park? Well, yeah, we do. There's not one there. Who's responsible? Who's responsible for making sure the citizens of Thorncliffe Park, one of the fastest growing areas in the province, have access to something other than walk-in clinics? There's a community health center across Don Mills Road, but you walk around and there's a brand new Target store that's just gone vacant there, right? So I look at that and I'm thinking, wouldn't that family health something be great here? But who has the responsibility for planning that? We're still in this kind of this model of thinking about primary care. I was a primary care doc for 3.5 years, and we ran a small business, and we provided great service. We were open we were open till 9 o'clock every night. There were 2 docs with blank booking sheets there from 5 to 9 in the evening, and we saw all the kids in Bramalea who had coughs and colds and fevers. Parents wouldn't go to the emergency department. They'd come to they'd walk in from 5. But so it's possible, right? But we've still got that culture that these are kind of small businesses that run, as opposed to, no, this is a resource paid by the taxpayer of Ontario. We need to plan this resource in a way that makes sense for the needs of the population. So that's sort of where we're thinking. Now, if you were to get that organizational structure, Michael, could you think about actually a risk-adjusted approach? How many primary care providers there should be, how many social workers there should be based on how many new Canadians? Thorncliffe Park, maybe we should have quite a few folks there who, A, speak other primary languages, B, have social work training. So you can imagine actually planning the resources to a community for primary care based on a risk-adjusted, kind of approach to the social determinants of health. That would be very cool. And I think we've got the planning parameters necessary within the LHINs to do that. And I know a huge number of primary care docs in this province want to move in that direction. They see an enormous opportunity to take the foundation that's been laid. I mean, the foundation that's been laid is terrific. We have organized primary care that's rostered, that's responsible for comprehensive care, providing care to about 70% of Ontarians now. So what's the next step in that evolution? And I think it probably relates to something that talks about population health, that includes public health at that table in some way, shape, or form, saying, well, we've measured this population's needs from a public health perspective, and probably we should be thinking about the... So I think that the LHINs offer us an enormous... And they exist, and they are 10 years and they're functioning. This isn't a surprise to me. We spend a lot of time, their senior management team, this Friday we'll spend the day in Waterloo, Wellington. We spend one Friday a month just sitting with the LHIN teams in each one of the jurisdictions and talking about what makes them proud, talking about seeing what they're doing in the community. Our LHINs have really evolved over the last 10 years, much stronger in terms of planning, much stronger in terms of understanding their communities. I think they offer us a huge opportunity for evolving into that population-based approach that an ACO represents.
Before I go to the next question, I see a number of people standing at the back, and there's 10 or 15 seats, all right here. And don't worry, we won't be asking any questions to the people in the back. So please come down. It's not going to be disruptive. Don't stand for the whole time. Bob, let's move to a little bit more specialized area, and there were two that I wanted to get some insight on. One is mental health. So, a few years ago, there was really an emerging public awareness of the mental health needs in the community and the care gaps that exist. Probably the Senate, Senator Kirby's report was, a significant part of starting to lift our awareness of it, but certainly there have been multiple other reports and reviews. But if you talk to people in the mental health business, they don't really feel like anything's changed. There's an awareness, but we haven't really done much to address the needs in that area. Is there something we can look forward to on the horizon on that front?
I think, let me start off by agreeing with you and setting the foundation where we are today based on 2 bits of data. Wherever I go, I see Dr. Steve Drury is in the audience today. He's always in the audience whenever I'm there. Steve, thank you for all the information you provide. And 9 months ago, when Steve started sending me information about the challenge for folks who needed supportive housing in Toronto, he told me there are 8,000 people on the waiting list. His most recent email told me there are 8,500 people on the waiting list. Do I got that number right, Steve?
10,416.
Steve, that can't be possible.
That's what I said last week.
Is that what you said? Well, then the 8,000 must have been wrong.
The 8,000 was right.
And 2,400 in the last 9 months? Steve, what are you running? I'm teasing you. Steve does great work, the Canadian Mental Health Association.
He slipped me $50 just before we started.
So that's one number. Is we know from the landmark study done led by Vancouver around the housing needs of folks with mental health challenges that it's no good talking about mental health unless you're willing to take a total government approach, a whole government approach to it. And we've got funding. I'm embarrassed to say the next number because we have a mental health strategy and we have funding for supportive housing, but the number's 1,000 funding for 1,000 places. And we all know the budget challenges of Ontario. We know what the cost of providing. Steve knows what the cost of providing supportive housing is to the nickel. So clearly, we have to look at different methods. We have to be a little creative in this area. First of all, we have to take a full government approach. We need MCYS to the table. We need MCSS to the table. We need municipal affairs and housing at the table. We crucially need policing at the table. A little aside. Paul McKenzie at the Wellesley Institute and CAMH, fascinating paper, looking at the experiences of about 750 folks with initial onset of severe psychiatric illness, acute schizophrenia, manic depression, at that transitional age, 18 to 25, and their experiences with getting care. The time spent from initial onset of symptoms to identification and enrollment in a stable psychiatric treatment program, mental health treatment program, was 15 months. And these are 750, 800 patients, not across Ontario. These are in Hamilton and Toronto. So clearly we're not responding in the way we got lots of ACT teams out there, but somehow our system is not responding well. And in terms of that transgovernmental approach, during the 15 months that folks were waiting to get into psychiatric care, mental health care, they had on average 5 encounters with the health system. What's astonishing in his paper, 5 encounters with the police and the court system. So, the data that I think comes from Toronto Rehab is 60% of people in Ontario jails have head injuries. that's a bit of a shocker, right? And maybe it fits with high-risk behavior and stuff, but maybe it also fits with the fact that undiagnosed behavioral issues lead people to be in the most expensive form of supportive housing, which is jails, right? So we need a full government approach. And I must say, listen, my role is not political, I'm an agnostic, but I must say that Kathleen Wynn's approach to looking at government resources, whether it's transparency, open government, or whether it's saying, in order to solve the problems we want to solve, let's start to address the issues related to mental health. We need all ministries at the table. That is true. Nancy Kennedy and our ministry, ADM Nancy Kennedy, is leading a table that's got all ministries at that table, and it's just in its beginning stages. The other thing we need is the sense that mental health is a health problem. It's also a social issue, right? And it requires some innovative social thinking. So one of the things that we're doing, Steve, you're going to like this, so one of the advantages of being CEO at UHN is you get to know a lot of rich people, right? You do. And you get to tell good stories to try and raise money to do great things. And I'm looking at Joseph when I say that because nobody's more expert at this than Joseph. But one of the things we're talking to some well-off Ontarians, Torontonians, and saying, let's talk about social impact bonds for folks who need housing. We often hear from philanthropists, Joes, we hear, don't just ask us for money, show us what the impact is, and show us, and sometimes they say, show us how you're going to earn back money in that. So that's one of the things I think we can actually do, and Steve's given us some of the data on this to say, okay, give us some money, we'll put people in supportive housing, and we'll measure how often they go to jail, because we know how often they go to jail today. We'll measure how often they're in the emergency department, and maybe we'll pay you back part of the money. Anyway, that kind of a social approach to this, it's got to be whole of government, whole of society approach, because a homeless person impacts each and every one of us. That was a long-winded answer.
That was a good answer. Similar kind of preamble around end-of-life care, right? And this is one where I think we all know that there's a real opportunity to take pressure off the acute care healthcare system and to actually meet people's wants, to not die in a hospital, to die in another place, but in a supported way. What can we do to really increase the availability of those kinds of services?
Yeah. So many issues, right? I mean, first of all, foundationally, what happens today? You're absolutely right. You do a survey of Ontarians, and I'm a cancer guy. I know the cancer stuff well, but this extends beyond cancer. If you ask cancer patients what kind of end-of-life care do they want, they say, I want to be at home, I want to be surrounded by my loved ones, I want to have a doctor doing house calls, I want to have somebody who's going to manage my pain. Manage my pain is a big issue, but that's what I want. And if I have to go to a hospital to manage my symptoms, so be it. And so that's what folks want. And right now you can look on www.csqi.ca, and the Cancer System Quality Index will tell you that most people with cancer diagnosis in Ontario die in hospital. It's like, I can't remember the number, but I think between 50 and 70% die in hospital. And if you look at visits to the emergency department within 2 weeks of death for cancer patients, like 80% of them are coming back and forth to the emergency department to get access to symptomatic management. So obviously we're not responding to the needs of consumers in this regard. We're also, I think as providers, I mean, it's very interesting to look at what the Supreme Court just told us in the Carter decision, right? And that I think Canadians are telling us that they're way beyond the paternalistic approach to end-of-life care that probably healthcare providers think through. That they want to determine, they want to have ownership of how they die. The Supreme Court unanimously thought that was appropriate. The other piece of information is some great work just done by Cancer Care Ontario and the LIN CEOs together on an approach to palliative care that would extend beyond cancer. And the gift they gave us was they said, okay, how are we going to define this? And they said, well, we got to start off same way cancer did. You know, cancer started in 2002 to actually change the cancer system. First thing they said, well, you got to identify who the cancer patients are, not just these people getting radiation and chemotherapy. What about those people getting prostate cancer surgery at St. Mary's Hospital, and and so figure out a way to define all those people. And you remember how important that was to the effort. So what this CCO Lynn initiative brought forward was for providers to say to themselves, whether you're caring for a patient with COPD, CHF, lung cancer, ask yourself the question, would you be surprised if this patient passes away in the next year? And if the answer to that is, I would not be surprised at all, that patient is a palliative care patient. Because there's nobody better at figuring out, the likelihood of a bad outcome within a period of time than the physician or the nurse looking after that patient. So let's register folks. Let's register folks who require palliative care, and let's start to measure their experiences. The other thing that I think links in extremely well here is health links. We know that that palliative care patients fit in that 5% category of folks who are absorbing a lot of resources as they head toward the last days of their lives. So, we're thinking that health links have a picture here as well. So, we're anticipating rolling out this palliative care enhancement approach. It starts with understanding who palliative care patients are. We're going to put in place more hospices in the community. This has got to be an enormous opportunity for home care. And the learning about the opportunity for technology to impact home care. These amazing new technology advances like the telephone. Right? A telephone's a very important instrument. As a cancer doc, telephone is one of the most important instruments you got. How's your pain? Well, let's increase your, we've got opportunities in home care, and I think one of the best places is in palliative care. So you're hitting all the big ones. This is a big challenge and a big opportunity. The other thing that's interesting, dying is a spiritual event for patients and their families. There's no question that it's a significant birth, death, significant moments. Joseph was so smart to bring obstetrics from the Toronto General Hospital to Mount Sinai Hospital. What a link. You get a spiritual link with supporters going forward. There's no question. And the sense of trust in the system, if people are afforded, if family members are afforded it's a hackneyed term, but a good death, a good experience at the time that their loved one passes away. Not an experience of, oh my God, I'm just vomiting with a new medication, gotta go into the emergency department, wait 12 hours, get admitted for 24 hours, go into general internal medicine ward where nobody knows my mom, get discharged, no information comes back to them, you know the story. Rather is cared for in her home in a respectful way. That moment of spiritual enhancement is something that could enormously improve the confidence that everybody has in our system. Surely we can get that right. It's tough, but it should be something we focus on.
So now we're done with the easy questions.
Let me hold your elbow.
Before we ask the audience if they have if they have any questions, I want to talk about the fiscal realities because they overshadow everything that we do and we think about. The government's done a very admirable job of holding down healthcare spending increases over the last couple of years. Of course, the pressures on the system continue to be there and probably to mount over time. And we're not going to be able to hold salaries to zero forever, and inflation is probably going to pick up at some point. in time. So, when you look at it from a longer term perspective, the challenge is ever looming, and of course we still have a deficit. So are we going to have to do something else to keep the fiscal integrity of the healthcare system there and still leave room within the government for education and roads and all the other important things that government does?
Yeah, thanks, Michael. Well, obviously it's a challenge and not other solutions. But there are a few things I know, and some of them we've been talking about. It costs about $72,000 a year to put somebody in long-term care. You can buy a lot of home care for $71,000, especially if it's technology enabled. And I think we all have a sense that better care, better quality care, certainly care that Ontarians want in terms of access. It doesn't cost any more money to get access to your primary care provider within 24, 36 hours than it does to get access in a week. Many of the things that we're talking about here are not more costly, right? They're not. In fact, many of them are more cost effective. I got a real sense that if we think about home care from the outcome that we want to achieve for the patient, as opposed to defining home care by hour visits, that, with the natural creativity we're talking about, we may come up with some very cost-effective solutions. And again, I'm going to refer back to Kevin Smith's work in integrated care post-discharge from Hamilton. He showed the most important feature in terms of discharging patients earlier, shortening length of stay and saving money for the system, was having somebody available 24/7 to answer the phone, right? So the patient phoned and said, there's a little bit of oozing coming between staple number 4 and number 5, my left leg wound following my total hip. The person on the phone, well, don't worry too much about that. Don't come into the... But seriously, patients do go to the emergency departments because day 4, they see a little oozing coming from the wound. They say, I may have a wound. On a telephone. So there are a bunch of cost-effective things we can do. Now, you're right, though. I'm not Pollyanna, right? We've got investments that are necessary. Some of those investments probably need to change. I think probably the days of building total cost of ownership, probably total cost of ownership new hospitals at $2 billion. We're all thinking that maybe a more nimble approach to providing resources that aren't mega hospitals, maybe more nimble going forward, so we've got some capital opportunities. One of the things that really intrigues me is, we could have actually probably spent this hour talking about IT between the two of us when we were starting this conversation, which has been intriguing. But, some of the things that are a challenge, so replacing hospital information systems. Like every hospital in this province virtually wants to, unless you got a Cerner in your shop, you want to replace your hospital information system. And the opportunity of plowing vast amounts of Ontario dollars into the farmlands of Wisconsin and Kansas, that potential is huge. But I think we've also got some very innovative homegrown systems starting up. And we've also got some private, we've got some private stuff happening. And when I say private, we've got pharmacies, right, that are very innovative players. And so far innovative at the margins. But, how can we make use of the sort of mutual advantages that we might have for IT enhancement with our pharmacy partners, for example? Lots of opportunities to do things in a more cost-effective way if we're smarter. And I think, goodness gracious, if the whole connected backbone philosophy works of IT enhancement at point of care that seems to be working in Southwest, that Peter Ross has promised me is going to work in CGTA. It will work, I'm sure, over the next little while. We get 30,000 users up and running and get it going. That opportunity to keep on linking things, to link in the immunization records, to link in the EMRs, to link in the drug viewers, to link in all the drug systems. Boy, there you go. Suddenly you're starting to ask yourself, you got all that information in point of care, Do you really need a brand new hospital information system? You probably need some decision support stuff floating on top of that somewhere. But, you know, I think we need to think about the cost effectiveness of IT as we think about the cost effectiveness of everything. And, you know, I'm going to go back to Dr. Hoskins' thing about, if you're going to think about a major investment like a hospital information system, let's put the patient first in that analysis. What does the patient get out of that? You know, does the patient get e-prescribing, so it's easy? Is there a cheaper way of giving that? So that's the kind of thinking that we're doing.
Thanks certainly to Longwoods for organizing what has been an excellent series over the years. But Bob, thanks for taking time out of your schedule to join us and to share your thoughts.
Thank you, Michael, for this interaction.